So we are kicking off our next block, our oncology block, and I am delighted that we have a preeminent speaker to kick off as a mini visiting professor. Someone who really embodies surgeon, scientist, investigators, someone who by reputation and in practice really can do it all in terms of complex surgical care, cutting edge research, and leadership in urologic oncology. And this morning we have Dr. Alexander Kutikov, who is professor and chair of the Department of Urology at the Fox Chase Cancer Center in Philadelphia, where he holds the Robert R. Scheller Endowed Chair in Urologic Oncology. Dr. Kutikov specializes in treating urologic tumors through both minimally invasive techniques such as robotic and laparoscopy and through traditional open surgery. He obtained his bachelor's in chemistry summa cum laude from Emory University on a full merit-based scholarship, where he represented Emory at Oxford University in England during his junior year. Dr. Kutikov obtained his MD from the Harvard-MIT Health Sciences and Technology program. He completed a urologic residency at the University of Pennsylvania, as well as a 2-year fellowship in oncology at Fox Chase. Dr. Kutikov has authored numerous seminal manuscripts, including on the renal nephrometry score, a pivotal tool used in assessing complexity of renal tumors. In addition to over 300 original manuscripts, peer-reviewed journals, and authoring the leading chapter that everyone has read, the definitive chapter on adrenal tumors in Campbell Walsh. Dr. Kutikov is recognized by serving in leadership roles in the American College of Surgeons, the AUA, and the SUO. And I'm delighted that he will be giving his talk this morning about kidney cancer, unmasking the truths. So let's welcome Dr. Kutikov. All right, so should be able to turn up.
Okay. Just click on this, right? All right. Perfect. Great. Well, this is a real privilege to be here. As a Harvard med grad, coming to Yale is mixed emotions, but no, this is, I think last time I was here was when I was 17, touring colleges. So it's a real treat to be here. Thank you for the invitation. So I'm going to talk about some of the mythology that we have in, I think, all of our fields, but especially in urology. There are just really strong beliefs that a lot of us hold about certain aspects of the diseases that we treat. And it's always interesting to look under the hood and see what underlies those beliefs and how we can potentially improve care by questioning them. So let's see if I can just move this here. Okay. All right. So this is, I put this slide up because a lot of the things you learn actually in residency. And I was a Penn resident, who are now my biggest competitors in the city, but had my loyalties to my residency alma mater. And I just went to Alan Zween's retirement party. These are the two things I heard in residency a lot. One was John Duckett, who I actually didn't meet. He passed right before I got to residency, and he was this giant in pediatric urology. And he had a Campbell's chapter that started with, when opinions abound, truth is hard to find. And whenever I see a debate at the AUA or see some disagreements on Twitter, like the more vehemently people argue, it really is true. The harder it is to find the truth. I mean, there's just, you get into sort of almost religious fervor in some of these opinions. And it is, that to all the residents and the medical students, that should be an opportunity. That's an opportunity to answer a question. That means the question is really not answered and people have very strong beliefs, but because when the evidence is strong, all the opinions sort of go away and everybody comes to consensus. So, and then I have Vic Carpinello, who still practices. He's in his 80s, and he was a private practice urologist at Pennsylvania Hospital, which is actually, all my 3 kids were born in this hospital. It's the first hospital in the United States. And he used to say, buddy, you ask him, Vic, why are we doing this? The textbook says that. He says, hey, buddy, it's urology. Whatever you do is right, And I used to think that's, that's sort of cavalier, and he, doesn't know what he's talking about. But as I've gotten older, that almost rings true. Well, we 10 years ago said this is the right thing. Right now, we're doing the 180 opposite, and now everybody's saying that that's the right thing, right? So anyway, I wanted to kind of go through. Let's see now if here we go. All right, so I wanted to go through, and I made this talk when like all this. This is I created Midjourney and Dali. This for some of the images here. I was playing around with all the stuff that came out. What's like 6 months ago, and so we construct these myths in urology, and this is going to be sort of some of the kidney cancer myths. So some we construct, and I think we can reconstruct and restructure to help better care for our patients. And this is going to be sort of a sampler. We're going to go fast. We're going to go through a lot of topics. These topics, each one of them is probably a weekend-long seminar, but we'll just kind of go through and sample some of the things that we hear in the kidney cancer space, and what I'll challenge you to sort of question as you see these topics come up. So first is, we talked about this at dinner last night. This was kind of, I'll call it a myth. This concept of that, despite the fact that we're finding more cancer, and despite the fact that we're operating on more cancer, we're actually not moving the needle on kidney cancer. And this came from this sort of seminal work from Michigan, where they showed that the incidence of kidney cancer is rising. Number of surgeries that we do for kidney cancer is rising, but cancer-specific mortality and overall mortality also rises. Okay, and so this concept was called treatment disconnect. And this paper from 2006 was sort of out there, and was, one of the most referenced kidney cancer papers out there. And so my partner Mark Smaldone and I sort of said, well, can we just look at this treatment disconnect thing? And we have a very talented statistician, Brian Eggleston at Fox Chase, said, can we let's harness sort of Brian's talents and look at these data again. And we sort of dug under the hood, and there was a lot of questions about how imputed missing data was used, how you could sort of adjust for incidence rates. And we wrote this paper that was sort of a little bit more nebulous than you would want to, but basically, and we actually had the Michigan guys come in on the paper because there was sort of the analysis left more questions than answers. But basically, the 2006 paper, I think, it sort of simplifies some of the data. The data are much more complex, and without going too much into technicalities, the more kidney cancers you diagnose, the way the registries are indexed, you're just more likely to index a kidney cancer death just because the patient had a diagnosis of kidney cancer. And we sort of try to flesh this out in this paper, which is in Medical Care from 2017. But if you actually adjust, sort of the mortality rates by an incidence ratio, we actually may be making more of a difference than we think. So, something that, again, when I having written this paper, seeing the narratives out there and the sort of strong, headlines, mortality rate is going up, mortality rate is going down. It's actually very hard to tell what the mortality rate is. And it depends on a lot of things. There's a lot of missing data. How you impute it matters. How you account for the rising incidence or lack thereof matters. So whenever you see those, that's an opportunity to look at that closer. But what we do know, regardless of whether we're moving the needle on this, is that there's opportunities to match renal mass biology to treatment intensity, right? Not just because we have a hammer and we can do a robotic partial doesn't mean we have to do it on everybody, right? So the other thing is, I think bladder is complex, prostate, there's all these debates, but kidney cancer is prescriptive. You got a tumor, cut it out, right? And so I think we've contributed a lot to literature sort of speaking to the fact that that's really not the case. There's a lot of nuance here. There's a lot of opportunities to really optimize the care that our kidney cancer patients receive. And so I wrote this paper with Dina, who's now in California, and we sort of broke up, in order to understand something, you have to really break it into parts. So there's kind of 3 decision points if you really break up kidney cancer care. There's decision point number 1, which is to treat or not to treat. You surveil it or you treat. When you treat, is it thermal ablation? Is it partial nephrectomy? Is it radical nephrectomy? And maybe after most recent trials, is it radiation? Right? You can radiate some of these tumors. And decision point number 3 is how to treat. And that's decision point number 3. If you go to our meetings, that's what everybody is talking about, right? Is, like I said last night, it's sort of left nephrectomy with right hand versus right nephrectomy with left hand. I mean, that's what urologists love to talk about. But it's probably the least important decision, right? I mean, after 6 weeks, what kind of scar you have doesn't really matter. Make sure you got good surgery. And so, active surveillance in itself can be broken up. And this, we call it this risk funnel. This is patient risk, tumor risk, and patient preference. And you sort of go down this funnel and you figure out how safe it is and what the patient's preference is in treating these tumors. We've written a lot about this. I mean, some of the big triggers. There's really, for the residents, linear growth rate of more than 5 millimeters a year. I mean, if that tumor is growing rapidly, that should be the biggest trigger for treatment for active surveillance patients. Otherwise, a lot of these patients, especially you're frail, you're elderly, they can be watched, and you want some of the biggest impacts that you make in clinic. At least for me, I walk out of clinic, and how many patients I didn't got sent to me for surgery I didn't treat today. I think one of the most gratifying things you can do in a practice. So to go more deeper into these decision points, we wrote this paper with Mark, and we sort of kind of reworked it with Mark Smaldone and reworked it with Thino. I'd like to just go through this a little bit. This is some of this patient specific and structure specific risk factors, and they all sort of filter down to your 3 goals when you're making decisions about what to do with your kidney tumor patients. Is oncologic efficacy, that's obviously number 1. Nephron preservation, we'll talk about that a little bit more. I think there's a lot of debate around how important this is. And minimize treatment burden. Basically do minimally invasive. But when you really sort of look at it, there's so many factors that come in there. There's patient-specific factors, comorbidities. There's one of the things on here is I think doesn't get talked about is anticoagulation. These patients with drug-eluting stents, with history of DVTs, and that decision about a radical versus partial versus ablation, I think that's a really key factor. Is that you're doing a really complex partial on a patient who needs to be anticoagulated, rapidly after surgery. Huge decision there, and I think you have to calibrate that carefully. We'll talk a little bit more about sort of radical versus partial, but call a lot of these elderly kidneys. You have a person who's elderly, who's got a complex renal mass. Maybe it's not that big, but it's complex. They have a normal contralateral kidney. Sometimes it's not a sin to just do a simple operation and not do anything fancy and just get them through a surgery without putting them through a gate of risk that's kind of unnecessary. So your contralateral kidney status, prior surgery, GFR, and then there's all these tumor factors that we've written about a lot through the nephrologist coordinator, tumor size, anatomic complexity, location, et cetera. So all those, there's patient specific, but then there are also structurals, surgeon skill set. Socioeconomic status. Some of this, honestly, we see patients from really underserved areas that are driving to us, for miles and miles. And I'm a little bit more nervous doing a complex partial nephrectomy on that patient. They don't have a good ER. They don't have good IR support. If there is some sort of problem, they're sort of stuck out there, somewhere in middle Pennsylvania, and they really can't get to us. Access to multidisciplinary care. So, this sort of concept of kidney cancer care is very prescriptive, I think is false. I think there's sort of a lot of nuance that goes into every one of these decisions and as to what to do with each patient. So nomograms, I've done a number of nomograms in my career, and we have a whole website dedicated to nomograms, but I just wanted to speak to that. So nomogram, and I see this in meetings, it's like nomogram said this. And you want to push the pause button and say, wait, hang on, let's understand what these nomograms are actually designed to do and how they're built. So this is, this kind of was seminal paper in my career. It was a JCO paper where we looked at competing risks of death. So if you have a tumor of certain size and you have a certain comorbidity status, your chance of kidney cancer death is the red area, and your chance of other cause mortality is the blue. And depending on how you stratify them by comorbidity status and tumor size, you could see that your bigger tumors, less comorbid, were more likely to die of kidney cancer, and vice versa. And you could build a nomogram and sort of have this predictive model. We added comorbidity index, and people were using this to make decisions in the clinic. If we sort of tumor of this size, you're this age, these are your chances, right? But if you really look, what is this based on? This is post-treatment data, right? This is all these patients got treated, okay? And these were their risk of mortality from these causes after they were treated. And that's not the same as saying if you didn't get this tumor treated, that's your mortality from kidney cancer, right? It's very different. So you have to understand all these nomograms and how they're built. And active surveillance in administrative data sets is, especially for kidney, where you don't always get a biopsy, it's very poorly indexed. I mean, any paper you see on active surveillance from an administrative data set in kidney has a lot of flaws. Active surveillance and administrative data set is really very, very advanced patients that got biopsied and didn't get treated because they're comorbid usually, and their cancer-specific mortality is astronomical in those data sets, and just because it's not really the active surveillance patient cohort that you really think of. Here's a great effort from Sarah Sutka and the Mayo Group. Also, it's a great effort, but it's has the same problems, and this is 10 years later, where again we're trying to make treatment decisions based on post-treatment data. Who got selected for ablation, who got selected for partial, who got selected for radical. Those are very different patients. Sort of decisions were made in these clinics for certain reasons, and all those biases are stitched into that data set. So to calculate risk based on post-treatment data is flawed. But there are jumping off points, these nomograms, and this is a website that sort of a project that we've had at Fox for a number of years. So you have these nomograms and you have these risk models that get put in the literature, and nobody uses them because it's very hard. Like sitting there in the clinical trenches and with a ruler and putting that out, and I mean, for the medical students, this is a nomogram. This is basically you calculate all the risks and you add them all up and you add up the points and you go down to the last line and you calculate your risk. Like that is a non-starter in a busy clinic. All right. So we've used this website, cancernomogrammers.com. We've basically operationalized all those nomograms, and you can just, click and get an answer. And actually, this is pretty quick. I do use it. The innovation here was we figured out how to take the figure. We didn't need the model that the monogram was built on. We took the figure that was really publicly available in peer-reviewed journals, and we made the web widget off the figure. So we actually have everybody's nomogram on here. If you see a nomogram in the literature that's not on this website, just email us. It's we sort of have the know-how how to put it up within weeks. But here's a paper by one of my dear friends and colleagues, Andres Correa, who one of my partners. This is looking at the ASSURE data set, one of the prospective randomized adjuvant trials in kidney, which and he basically took that data and applied different nomograms, different predictive models and nomograms to those data, and you can see what the outputs were. Basically, your TNM staging is, your C index is, or its area under the curve is 60%. What does that sound? 60% sounds high. Well, 50% is a coin flip. Okay. So 60% is not even halfway between a perfect prediction and a coin flip. It's a pretty terrible prediction. And you can see that, S sign, this is the Mayo Clinic score, gets to, halfway between a coin flip and a perfect prediction. So, and these are the best models that we have in urology. And this was sort of a very sobering paper where, the predictive models we have are quite poor at actually predicting what's going to happen to each individual patient. Current decisions, just in every field, these predictive models have to be taken with a grain of salt. You can't hang a decision hat on them, but it's helpful as a jumping off point, just to kind of know where the risks lie. But still, a lot of clinical gestalt and decision making, sort of plays into our everyday decision making. All right, renal biopsy is one of my favorite topics, and I grew up in an era where it was like renal biopsy, there was no role, nobody biopsied, and then all of a sudden I started coming to these meetings 10 years later, and it was it was like a cardinal sin not to biopsy. I mean, there was centers that were saying we biopsy everybody that comes into our clinics. And it's like, wait a minute, it doesn't make sense. And I mean, whenever we're at these meetings and people say these things so strongly, like, don't take that, that doesn't mean it's true. It's just, there's always in medicine, there's an opportunity to investigate it. And even things that I say very strongly are completely not true. And, investigate it, ask questions. And it's always, there are careers to be made on all the things that people believe are sort of airtight, right? So, here, let's talk about biopsies. So there's, there's lots of fish in the sea, right? They're the sharks, right? There are these huge renal masses that are the man eaters. You know them right away when you see them. But then there are all these minnows, and out of the minnows, some of them are sharks, but most of them are really minnows. And so, the minnows are actually, a quarter of the renal masses. I mean, there are these, lipid poor AMLs or oncocytomas that have no metastatic potential. I mean, they really don't cause any problems. They can be left alone. And if you look at, this is a private payer data set, okay? It's one of the seminal papers from Stanford that showed that if you look at, forget Medicare patients, you look at a private payer data set, and you look at partial nephrectomies that were done in the United States between 07 and 14, and this is the end here is 18,000 patients. 30% were benign. I mean, we're massively overtreating this population. These patients do not need surgery, and we're just, taking them for surgery. And as you know, everybody's been on surgical wards. There's PEs, there's strokes, there's heart attacks. I mean, you take somebody to surgery, there's, the repercussions. And so, out of the 30% with an oncocytoma, how many had a devastating stroke or passed from a PE? It's not trivial. So then most of the renal tumors are really indolent cancers that can be watched for years, and especially in an elderly comorbid patient, they're never destined to catch up or cause symptoms to that patient. And then there are the man eaters, right? So our biopsy is really excellent at differentiating between, from the minnows from the sharks. Okay, so your biopsy is very accurate for telling you what's a benign mass. All right, and that's very, very useful for the right patient. But it's not very good about kind of telling you what kind of shark it is. And to say it another way, it's not very useful for grade. It can't tell you what the tumor grade of a particular mass is. Biopsy is, however, is safe. It's the complication rates are across studies are low. You basically, when you biopsy somebody, you're worried about hematoma, and the rates are low, but it does sort of prevent an immediate partial nephrectomy. You have to consider that a little bit. Pain and isolated case of classic retention. I mean, those are all quite rare. But not zero. And so the big thing that was sort of flaunted as a huge risk back in the early 2000s and the 90s was this needle track seeding, and then everybody sort of moved off of it and said it never happens, right? Well, it does happen sometimes. And so this is a paper from just a few years ago from Oxford, where they basically, it's a case series from UK. It's 7 patients with evidence of tumor tract seeding at resection. Now, how clinically significant is unclear. I mean, they resected the kidney or did a partial, and in the fat around the tumor, they saw that there was actually needle tract seeding, right? Is that clinically significant? Unclear. 2 of the 173 patients biopsied at the center, other 5 were referred in. So you actually don't know what the denominator is here, right? This is a tertiary referral center where all these patients are coming in. You actually don't know what your rate of needle tract seeding is, because you're just sort of consolidating patients from across the UK. And 1 patient with systemic spread. So we were at this editorial with Tony Finelli kind of saying, well, the true number of total mass, kind of the denominator is not available. Clinical significance of seeing, some cells in the tract is really unclear. And sort of some of these patients the 1 patient that had evidence of clinical recurrence, I mean, had positive margins, he had multiple sites. I mean, these were very sort of aggressive patients with aggressive disease. I do think that our conclusion still stands that this isolated report should not influence current practice. But I mean, when I have a 40-year-old in front of me, I think about this, that the risk is not zero. There is there is potential here, especially for an aggressive mass, that it can seed the tract, although I think the risks are incredibly small. So this is my daughter many years ago now, and she hates fishing. So it's, so do you need a biopsy? Like, do you need to be fishing here, right? And so the argument is, you have the same renal mass in different patients, right? You have the surgical patient and you have the active surveillance patient, right? And you could argue that, you actually, in these patients that they're screened, you don't need a biopsy. You know what to do anyway. Biopsy is not actionable. So let's talk about the active surveillance patient. You already chose a patient for active surveillance. What's a biopsy going to do? Why do you need a biopsy? You're watching them anyway, right? Remember, it's not very good for grade. High grade biopsies are very rare. Okay. However, if the mass starts growing on surveillance, then I think that patient is appropriate for biopsy. Before you take that, elderly comorbid patient for surgery, hey, make sure it's not oncocytomas, because hey, oncocytomas grow just as rapidly as aggressive cancers. The growth rates of oncocytomas can be quite rapid. You have, this is actually very rare patients. So Phil Perazio and Serena Martin have shown sort of this quality of life assessments on inactive surveillance patients. And these patients that are nervous about surveillance, if they're appropriately counseled, are actually very rare. And I think we see that. They're actually different patient populations from our prostate cancer patients, honestly. But yes, there are patients that sometimes just really want to know, and they won't watch, and they at least biopsy them to rule out the oncocytomas. Otherwise, just leave them alone. And again, not very well described. I'll just give you sort of a clinical example. I always thought that when a patient gets a path report that says cancer, all of a sudden it's like, it's like Schrodinger's cat, or like, Heisenberg uncertainty. Like, you measured something and that's it. It changes the state. And I just had that just very recently in clinic, where this man has been on surveillance for literally a 2.4 or something centimeter mass for years with me, and it's inched up by centimeters over years. And he said he's going to lose his insurance. He's going to lose his insurance if we don't show that this is benign, because they're saying he has cancer, and they won't. He's had life insurance still, and he's saying he was going to lose it. So I said, okay, we can biopsy it. And if it's, oncocytoma, you get to your insurance. But if it's cancer, you're going to lose your insurance, and you're going to lose it anyway if we don't biopsy. But I said to him, but remember, it might say cancer, and I think it may affect how you think about this. He's like, no. I mean, like clockwork. He gets a biopsy, clear cell carcinoma. His wife, gets very nervous. He gets very nervous. And, we have to ablate this thing that I would have watched forever, would have never treated. Right? I mean, I think it perturbs the equilibrium, having that biopsy. I think that's an opportunity for a study. If somebody can, sort of survey these patients and show that, I think before biopsy and after biopsy on surveillance patients, treat their masses very differently. So what about surgical patients? I think here we really don't need to fish either. Utility of renal mass biopsy is restricted by its inherent limitations, right? Oncologic safety is paramount, yet sensitivity for high-grade disease is imperfect. We're not great at picking up high-grade disease. The results are not always actionable. Okay, if I have a 45-year-old, I biopsy them and it's an oncocytoma, what am I doing with that? Am I really watching them for the next 4 decades and bringing them into clinic every 6 months?
It was Chinese New Year's there.
Sorry. Yeah, no worries. This is in my department. This happens every 5 minutes. I'm impressed. I'm not going to go through all these numbers, but basically, when you look at a little bit about grade concordance on biopsy, people have said that accuracy can be improved up to almost 90% when you group, instead of indexing concordance as grade 1, 2, 3, and 4, but doing high grade and low grade. If you look at all those papers, accuracy is actually a very misleading metric, because it really depends on your rate of high grade disease. And for instance, in Canada, high grade disease, for whatever reason, is low, whereas at our center it's almost 30%. So the concordance of your biopsy for grade is very different based on what your rate of high grade disease is, because accuracy collapses the
this sort of calculation. You know, if you have 99% low grade disease, well, you are going to be 100% accurate for grade because you just don't have any high grade tumors, right? And so sensitivity for detection of high grade disease, I think, is a much more meaningful metric here. But so prior to biopsying a young patient or a patient that's going to really stay on surveillance for a long time, you have to really have this conversation: is what are we willing to tolerate? There's about a 5% risk of hybrid malignancy for a solitary mass. For solitary mass, if you biopsy and it's an oncocytoma, 5% chance that you have a coexisting malignancy in that oncocytoma. Not large, but you have to tolerate that risk. Lack of long-term safety for oncocytoma. This is very controversial. But you know, when you look at the data, the largest series is 81 patients, 2.8-year median follow-up. And the risks must be really low, but people say, I've never seen anybody die of an oncocytoma. My answer is like, okay, I agree. But you know, in your 45, 50-year-old patient, I've seen people die of metastatic chromophobe. We don't actually know if you know, those are very related tumors. And you know, I don't want to be alarmist here. Oncocytomas are super safe. You should leave them alone. But in young patients over decades, it's unclear. You know, we need data to really to kind of leave them alone long term. And need for lifelong surveillance. I mean, not every patient wants it, and some people do. Some people say, just watch it. I don't want surgery. This is not what I want to do in life, and just, you know, I'll keep an eye on it once a year, and that's fine. So we wrote this editorial with Mayo, with Brad, and this was after we were sitting. This is actually Brad and I watched standing at an AUA and watching one of our colleagues kind of say and pound on the podium that everybody who comes into clinic needs a biopsy, and so we wrote this editorial that, you know, kind of, you know, just basic outlining what I just outlined, but we concluded it, you know, sort of renal biopsy, always, sometimes, whenever. We concluded more than never, less than always. I think it's a really good tool to deploy, especially for your elderly and frail patients. But you certainly, I don't feel strongly need to biopsy everybody. So yeah, just catch the fish you need to catch, right? But practicing without biopsy, I think is also irresponsible. It's kind of thoughtless. It's lucrative. You offer it to everybody. It's inappropriate. It's like blast fishing, right? You catch too many minnows, and you know, you catch sharks that don't need to be caught. So I think the art of this kidney kids practice to deploy biopsy sort of at the right rate. All right, what about Sestamibi? So, you know, this paper from Hopkins came out in 2016, and I think there was a lot of excitement about it, where this is basically an agent where you can, you know, you can assess the likelihood of presence of an oncocytoma by doing cross-sectional imaging. And a cold Sestamibi is consistent with renal cell, and a hot Sestamibi, because there's a lot of mitochondria in oncocytomas, indicates an oncocytoma. And so we really deployed that at Fox Chase, and we started sort of, instead of, I mean, and it's easier. I mean, instead of sticking needles into people, you just get a scan, right? And so this is the kind of the, you know, sort of very recent sort of meta-analysis, and it all kind of looks very promising. But you know, all studies in this review are really designed in similar. Pathology was required for every patient undergoing Sestamibi, right? So I mean, everybody got resected, and so there was no actual kind of any selection that was applied. But what happens in the real sort of world clinical practice, where you don't biopsy everybody, you don't get a Sestamibi on everybody, but you get it on only certain patients for whom you think the results will be actionable. So we did it at Fox Chase, and we actually, our rate of benign disease at resection, so we're now part of Music Kidney, and we were doing that even before, we would report to each surgeon what's your benign rate. Like your benign rate, if it starts floating up above your colleagues, you know, you got to rethink how you're, you know, what you're operating on. You know, our benign rate jumped up to 20% with Sestamibi. I mean, we were basically operating on a lot of oncocytomas that would have been picked up as oncocytomas on biopsy, and Sestamibi was missing them. So this is so one of the first clinical interrogations of Sestamibi in actual real world practice. And I think the difference here is that we, you know, this was the select patients in whom you would make a difference, and they're not enriched for these large renal masses that are definitely cancer, and where your Sestamibi, again, contributes to your accuracy. Yeah, we just had very different results, and we just presented at SUO sort of reanalysis of this data set, trying to do some quantitative thresholds, and, you know, sort of trying to see if there was an opportunity to sort of better better extract data from this data set, and it really doesn't work out, at least in our hands. And unfortunately, those Hopkins nuclear medicine folks are now kind of in other institutions that we've tried to kind of get together with them and understand. Maybe it's protocoling, although this is a very sort of routine test that it's easy to protocol. But yeah, in our hands, this really didn't pan out. We abandoned it. We're not using it anymore. This is Journal of Urology, 2023. So yeah, those patients who proceeded directly to treatment are excluded. Test characteristics suboptimal, right? All right, this is now my new love are these Bosniak masses. So this is one of these myths that I think really is ready to be debunked. I think there's a lot here. This is a really interesting area of research. We're doing a lot with this right now. So Bosniak score, you have, for the medical students, you have these cystic masses, and you have from 1 to 4, and 3s and 4s can be cancer. But if they're cancer, they're never aggressive cancer. Those are the kind of those are the teaching points that we've been taught. But and if you resect a cystic cancer, nobody dies from that ever. Okay, that's sort of cancer-specific survival for cystic renal cell is 100%. Now, if you look at all the literature on cystic renal cell, how are the data sets constructed? There are post-resection data sets. They're off-path reports, okay? And so I mean, it wasn't hard to notice, but what I noticed is I've been watching a Bosniak 4 cyst, and then I finally, it grows, I take patient to surgery. My path report doesn't say cystic at all on it. It says type 2, or back in the day, high-grade papillary carcinoma, necrotic tumor. It's like, wait, it was cystic. It doesn't say cystic. And this was a Bosniak 4 cyst, and that's supposed to be high grade, right? And so I had this hobby. I would take up all these cysts and I would open them up, and so I'd like, sort of folder full of these videos of and photos of cysts being opened to pathology. If you guys don't do this, very fun for residents. Just take your specimen up to pathology. They'll ink it and they'll open tumors. It's like you learn a lot from what these things look like inside. So here's a video of one of these. So 75-year-old male, CKD3, 10 centimeter left Bosniak 4 cyst, and surveilled, it got changed a little bit. I mean, this is like, that's it. See that little hyperdensity? That's it. That's all he had. A little hyperdensity right there, potential enhancement. So see if this plays. So this is after robotic partial, take it to path. Okay. Yeah. Pretty disgusting. And it's disgusting because it's all high grade. And here's the tumor and all that necrosis around it, right? So high grade, 10 centimeter papillary, right? And so we actually got this at the, we looked at this guy. This was cover of Journal of Urology last year. And here's sort of the data. We had this, and I said, pause. We can't go out there and put a paper out so everybody starts taking out every cyst they see, right? We can't give people carte blanche. So we looked at all of our cystic renal masses on surveillance, and here's our findings. So we basically found that of the ones we resected, 23% were high grade, which is really remarkable. Like, that was a remarkable finding for me. 23% of cystic renal masses. When the difference in this paper than most papers out there is that we constructed this data set from radiographic findings. In our, we have more than 5,000 masses of Fox Chase prospectively collected kidney tumor data set, and we index on radiology whether it's cystic or not. So we just pulled all the cystic ones radiographically. We actually went through all the scans with a radiologist, with a radiology resident. We reclassified them with a new Bosniak system, and so these were truly Bosniak 3 or 4 cysts and some 2Fs. And 23% of them were high grade. And important point in this paper is that if you had those that were on active surveillance, or those that were on, went to delayed intervention after surveillance, I mean, it was very safe. Nobody died, nobody met it out. So it's very, very safe to watch these things. But if they're misbehaving, if you're worried about them, there's absolutely good reason to operate on these masses. And so, here's another example. So you can see there's a Bosniak 4 with a little, this is a classic cyst with a little mural tumor. also high grade. But you can see that the kidney cancer survival is very high for whether you immediately treated or you did active surveillance.
Alex, in this paper, one of the things was there standard criteria for surveillance and for intervention, and are the triggers the same as what you do for solid renal masses? For instance, if someone has a 6 centimeter renal mass with a 1 centimeter nodule, the cystic component becomes 7 centimeters over a short period of time. Solid component stays the same. Is that a trigger for intervention?
Great question. No, this was just, this was our group and choosing to intervene on some, and this is a group, remember, this is a group that really sort of believes in and is a strong proponent of active surveillance. And this is a group where people walk into each other's OR and kind of say, you're operating on that, like that, there's that culture of like, somebody walks into your OR, you better have a leg to stand on of that you're doing surgery for the right reasons. And so these are, in that context, these are patients that went to surgery by these surgeons that kind of said, I'm worried about this. Like something is changing here. And I mean, it looks, whether it's the biology of these, and maybe even despite high grade, the biology is still indolent because really there was no metastasis in this whole cohort. But yeah, I mean, this is just real world clinical practice. There was not a standardized protocol of when the trigger for treatment is. And I honestly, even if you try to design it, I'm not sure I know what that is right now. I mean, I think it's I'll tell you that, we sort of, when we wrote this paper, we looked at all of our patients and we started operating on some of these, sort of heterogeneous things that not even enhance. Like we have a cohort of these that don't enhance and are high grade. They're just all dead tumor in there. So I think these, especially the big ones, big cystic masses that have a lot of heterogeneity, hyperdensity in there, like those things, some of them are, we're trying to come up with a good name for these masses, but we have this cohort of 7 centimeter or larger cystic masses. Again, some of them that don't enhance, and I mean, all of them, sort of more than 2/3 are cancer, and a lot of them, I think it's 60% are high grade. I mean, they're just like these necrotic things that are sitting there. And if you know exactly what the tumors I'm talking about, where they're just like, it's a Bosniak 4 cyst, but it's not. It's just a bag of necrosis. Yeah. Let's see how we're doing. We're getting a little more. Yeah, of course. Sorry. Yeah.
In your prior slide, was the rate of high-grade tumors the same in the delayed surgeries versus they take them right away? That 23%.
Oh, it's a good question. I don't know if I know that offhand. Yeah, it's a great question. Yeah, I have to look. I'll give a plug for Randall Lee. This is so this was a Temple resident who did into Guild Fellowship and came back and joined us this year. Really talented guy. It's actually pretty amazing. He's the kind of guy who, he's a young guy, first year of practice, and everybody comes to him, stays with him. It's unbelievable. It's like we didn't even have this picture on the wall. We have a picture in every room where like every attending, and he's walking in there and it's like, man, we got to get your picture up. Like first few months until we get a picture, it's huge. You're kind of really playing at a disadvantage because the patient's like, where are you, right? Still, I mean, our schedule is completely filled. He's just, patients trust him. It's like his one-on-one is amazing. I mean, amazing. I've never seen anything like it. I mean, in a very competitive city, he doesn't lose a single patient. Everybody stays with him. I mean, he's very well trained, does a great job. He's a really great partner. Yeah. And so, all right, partial, this is what, again, this is, I can talk about this for a weekend long seminar, but, partial nephrectomy for all. I mean, we hear this a lot, like, partial. And listen, I'm trained by a person who really pioneered, use of nephron sparing surgery, Rob Uzo, who's actually CEO of Fox Chase now. And, this is something that I think is important that, just because we can doesn't mean we always should. And I think here there's a lot of surgical hubris, especially in competitive markets where, one provider says, I can do a partial, and then they see another provider. I think it's important to be a force to say, does this make sense? I mean, sometimes you really need to do a partial, and sometimes it just doesn't make sense to put the patient through a partial. So this is kind of I made this slide my first year of practice. These are my, sort of, I was very fortunate to sort of inherit, busy practice. These are some of the, tumors that I thought were very complex in my first year in practice. And, they're sort of hard partials. And, I did partials on these tumors at that time. And really, when I came out of fellowship, it was a therapeutic sin to do a radical nephrectomy. I mean, you really were just anything that you could think you could do a partial, you needed to do a partial on. And thankfully, the pendulum has swung a little bit. I still struggle with this. I mean, I think every day I find myself making a different decision based on, we're talking about that yesterday. I think actually how the patient gets to you sometimes affects your decision. If a urologist who does radical nephrectomy sends your patient for a partial, honestly, that affects your decision making versus patient just seeking your opinion, right? I think this is, again, sort of not very prescriptive at all. So we talked about this, but partials has complications. And I think we have to remember that. We have to remember that because, they're real and they're rare, and in good hands, they're very rare, but they're still not zero. And, there's bleeding, there's urine leaks. And then the biggest complication is a non-R0 resection of a partial, okay? And that does happen. Nobody talks about this. Nobody likes to talk about it, but anybody who's a kidney surgeon, this happens. Thankfully, it happens very rarely, but it's very unsatisfying when it happens. And I'll show you an example in a minute. So, hemorrhage. I mean, sort of, 1.2 liters per minute goes through the kidneys. I mean, it's one of the most vascular organs. You're sewing something, you can miss a vessel. So, a poorly controlled, vessel in the bed is one of the main reasons. And I'm a big fan of early unclamping now. I think you find, you unclamp early, you do your base sutures, and then you can find these things that you would have, just never seen. And you probably, out of renorrhea would have been controlled. This is a patient of mine, solitary kidney, uneventful robotic partial, and, tough case. I mean, she actually stayed up dialysis, fine, healed, but it happens. And this is you can see how her, on the left panel there, you can see it's got a lot of cysts, these kidneys that have a lot of cysts in them. They just don't hold sutures very well. And, she bled sort of delayed bleed. This, I want to talk about this AV fistula and renal artery aneurysm. This is really, in reality, a poorly controlled artery in the bed. I mean, we give it all these names, and I used to always think, it's probably a suture that went through half the vessel, and you got this aneurysm. No, it's basically a bleeding vessel inside your renorrhea. Renorrhea got closed over it, and it can't bleed out. It's just bleeding inside this renorrhea, and it's decompressing sporadically into the collecting system. So you get these stuttering bleeds from the collecting system, and almost always those don't go away on their own. You got a really significant hematuria post partial nephrectomy, and then it stops. Like that patient needs an embo. Then you need to get that vessel, because that's just it's gonna stutter, and it's gonna prolong sort of the inevitable. And this is sort of a very complex partial I did on one of these end-stage cystic kidneys. I sort of was worried about it, very central. This is probably 10 years ago. I gave the patient my cell number, and this is the picture he sent me. Yeah. So yeah, brutal. He's okay. So you have to have high suspicion. You have to act on it. I mean, there are real complications of partial nephrectomy, right? And so this is a robotic partial I did on a young man. This was actually on oncocytoma. And here's your AV fistula. Pseudoaneurysm. See that there's the bleeding vessel, in the renorrhea. Here's they coil it, and the guy does really well. Urine leaks. These are more rare these days. I think our techniques for closing the renorrheas are better. But I just want to show this paper. This was Jeff Tomaszewski, who's actually just across the river in Kutikov, one of our fellows. We did this. Basically, if you have a completely intrarenal pelvis, your rates of renal leak are much higher. It's something about the pressure in the renal pelvis. And these extrarenal pelvises the rates are lower. And this is, sort of, Sometimes, especially a complex partial, you look at that and you can kind of give the patient a heads up that you're more likely to have a leak. And this data kind of, it's actually it's sort of very impressive observation and discovery that this was the case. Really fleshed out every time we looked at this. There's a couple papers on this. Intrauterine structures. It's actually not my case, but the residents got me a picture. Careful. You can hurt somebody. Oncocytomas. Gotta be careful too. During your intersection. And the one thing I haven't done this in practice yet, but I've seen it around the city. On the left side, SMA injury, devastating. I mean, really, what I would quote is a clean kill, just unsalvageable injury. Be very careful. On the left side, if you're lost a little bit, don't just start clipping arteries. Don't start, I think that's always a paranoid surgeon is a good surgeon. You kind of, every time you're in a case, you're in different parts, be paranoid about what can you hurt here. And on the left side, SMA is devastating. It's just an inexcusable injury. All right, so this is non-R0 resection. This is a patient that I watched. This is a very comorbid patient, and she had a Whipple in the past, and I just watched this mass, and all of a sudden, my PA, who's does a lot of the surveillance for me, she calls me. She says, "This mass is really growing rapidly. Can you see her?" And I see her, and it's growing rapidly, and we go in, and so this is actually Robin and me when I was in fellowship. And these are the risk factors for non-R0 resection. But this is, we go in and, I've watched her. So although maybe if she came off the street, I would have done a radical nephrectomy on her, but I've had on surveillance. I told her it's okay. And here it grew. So I'm doing a partial, right? And this is a retro partial. And here's the video. So, this is a thoracic roll. I love doing a thoracic roll. You can really retract for yourself and you can mop up the little bleeders. And on a retro, actually your vein kind of bleeds a little more just the way you're positioned. And look here in a second, you'll see I'm going through. And boom, you can see, there it is right there. See that? That's tumor. I just cut through tumor right there. And it sort of it's going deeper in. I say, forget it. We're going to just take this kidney out. Okay. And I think that right there, that the Rubicon is crossed. I think the risk for a patient, like people say, oh, I'll do a partial and then I'll complete a radical. That's a violation of planes for these aggressive tumors. It's, we have a video, there's no spillage. She had a ton of tumor in her retroperitoneum, 6 months later. I mean, so I think, these are rare, these are very aggressive, generally get away with it and it's fine. But I mean, it does happen. And this, when you least expect it. So I think you can't convince me ever that a partial is as good of a cancer operation as a radical. It's just not. There's some risks, to a partial. And so, yeah, this is, this high grade with sarcomatoid features. I mean, this is a really nasty player. Very rare, this shouldn't affect your management for, your garden variety renal mass, but they do exist. Positive margin rate is not good. There's, just kind of go through this quickly. There is basically, positive margins increase your rate of recurrence by tenfold. Again, the rate's still low, but your relative rate goes up. If anybody wants to kind of read my opinions on this, this is the 2017 collaborative review with Simon Kim that we wrote, and we really sort of spell out some of where the data support partials and where they don't, and how to really, I think about this decision. And again, struggle with this every day. People suggest to do a trial. Not sure it'll ever get done, but this is the Steve Campbell trial. Randomized trial has been proposed and it's never really picked up steam. And so this is a Twitter poll from a few years ago where, so I'll just walk you through this real quickly. Partial nephrectomy for most is the green outline. This is what the surgeon believes. Unclear, largely case by case, is the yellow outline, and then radical nephrectomy for most is the red outline. And then one is you need a trial, sort of ABC, and then if you need a trial is one, and trial is a waste is two. And so, the people have all these opinions. So, so Darwish, Ithar Darwish, for instance, says, I do partial nephrectomy for most, but I think trial is useful, right? But look at the KQR. This is the patient advocacy group. They're saying partial nephrectomy for most, but we disagree with the trial. Look what they say. Disagree. Too many patients still get radical nephrectomy when partial nephrectomy is indicated. A trial like this could swing pendulum further towards overtreatment. Let's focus scarce resources where they're needed. Right? So patients have a very different opinion from how we think about this. And I think that's why it's important to engage patients in these conversations. I'm with Mark Ball here. I think it's case by case, and I would like to see a trial because I think there's a lot of questions that are unanswered. So we're, every second counts, and we're sort of a little bit against time, but what I'll just tell you is that this is a seminal paper for Dipin Parikh, and who's now running a really great department in Miami, basically showing that the human kidney is very, very tolerant of ischemia. And it's really the preserved parenchymal volume that drives your patient outcomes, not your ischemia. And this is a great paper from just 2 years ago that took, this Steve Campbell's partnered with a Chinese group, and they looked at the tissue of radical nephrectomies for those patients who had a partial nephrectomy years prior, and showed that based on the CKD histologic score, which is what the kidney looks like histologically, it has, CKD status has nothing to do with ischemia and has everything to do with sort of medical comorbidities and sort of just intrinsic medical renal disease. And so we're in an editorial that urologists should stop the TikTok dance, and I think this is an editorial to help training. I think you can safely let your trainees cut out some of these tumors and not worry about a minute here or there. Segmental ischemia, sort of, this was a big push. I mean, really, I think it doesn't have a big role. And actually, if you really look at it, it only works for medial tumors, doesn't work for those exposition tumors. You can't really get them segmentally ischemic. I mean, just making a complex operation even more complex. There's the clock trial showed that, probably doesn't matter. And, just again, this right hand, nephrectomy with right hand, nephrectomy with, left nephrectomy with the right hand, right nephrectomy with left hand kind of concept where this one of my everybody likes this slide. This is a Journal of Urology paper. Probably one of the reasons why Journal of Urology impact factor is low, because they accept papers like this that nobody quotes. But this is where to put your clamp. So you can see, you try to hub it, but not hub it all the way. And that's where your pressure is the most on the clamp, okay? So dissect your artery enough and right there. And I mean, look, that pressure there is much higher than the pressure at the, if you clamped it at the tip, okay? That's tip is green. When you hub it, but not all the way hub it, is blue. But if you all the way hub it at the fulcrum into this little space, then that's bad too, okay? Oh, and 2 clamps. 2 clamps is money. If you're really big partial, 2 clamps is sequential. Like even in that video, you saw a little bleeder. That's clamped. It's just bleeding through the clamp a little bit. You put another clamp on, it stops that. I'm not going to go into this. Enucleation is sort of this complex topic. Basically, we did this prospective study showing that even if you say you don't enucleate, you enucleate at the base almost 40% of the time, more than 40% of the time. But again, don't get a positive margin when you enucleate, okay? And sort of, I mean, look at this tumor. You can look at, let's see if you can see this. Yeah, you can see this imaging. See that right there? If you enucleate it, you would completely get into it. So you can see that on imaging sometimes, and you can really get a wide resection if you look at your imaging closely. All right, so in some, enucleation is common. Deliberate enucleation needs no further study, and don't get a positive margin. I wanted to stop here to be respectful to time. So the kidney cancer myth needs an update. This is how humanity functions. We have our stories and we have our myths, and this is what we use to drive our actions, but they always need to be reevaluated.